being here. Oh, there we go, recording in progress. Thank you so much for being here and joining the meeting. And I hope I can tell you something useful about quality improvement. So just a little bit of background to build on what Mohammed said. I trained as a GP in Lincolnshire, goodness, a long time ago. In 1987, I trained at Caythorpe and Ancaster and moved up from London after qualifying at Barts, and then I started general practice in Lincoln in 1990 and really worked as a GP for 25 years. And during that time, I trained in research. I got my PhD in 2003 and then joined the university in 2004. And exactly as Mohammed said, my interest is around quality improvement. It's also called improvement science or implementation science or translational research. There are lots of different names for it. But actually, I learned about improvement working as a GP, and I'd like to share some of that with you, and hopefully some practical skills as well. As part of this talk. So I'm going to share my screen, if I may. So let's just do that. Host disabled participant screen sharing, it says. So I think Mohammed or somebody might have to. Oh, hang on.
Just changed it. Yeah.
Thank you.
Work now.
That's marvelous. So are you able to see that screen that says quality improvement now?
Yeah, I can see it. I can see your screen.
Okay, lovely. Excellent. So there we go. That's me. I lead something called the Community and Health Research Unit at the University of Lincoln, which is a research centre here. And it's a group of around 18 staff and around 10 PhD students. And I've moved recently, since April, to Lincoln Medical School. So that's where I'm sitting this evening, just to make sure that the Wi-Fi and the communication is good. So as Mohammed said, a few years ago, with Steve Gillam, I wrote a book. We co-wrote a book called Quality Improvement in Primary Care, the Essential Guide. So some of this relates to what's in the book, but actually things have developed quite a bit since then also. And in fact, I'm writing a new book called Quality Improvement in Healthcare, and we're developing some of the themes from the earlier book, but new things as well that have come out since then. So I'm just going to give a little bit of background. I'm not going to spend too much time on this. I'm going to talk about what is quality and quality improvement. How do you improve it? How do you evaluate whether you have improved it? And how do you design a quality improvement project? So those are the sort of things that I'm going to cover. And then I'm going to do a question and answer session at the end to try and pick up any queries, any comments, any other things that you want to learn about. So I think it is worth saying something about quality, because it isn't really that clear what we always mean, and that's because people mean different things when they talk about quality. And if you look at the Oxford English Dictionary, it's a standard or something as measured against other things of a similar kind. So we're comparing essentially, but very important is who's making the judgment. You know, is it the GP? Is it the patient? Is it the commissioner? And so who is making that judgment of what is high quality and what is an improvement is actually very important. And then how is that judgment being made? Essentially, how is that comparison being made? How are the measurements being done? You know, is this about numbers or something qualitative? And so that moves us on to the idea of quality frameworks. As many of you will have seen these concepts. and they're the most commonly used concepts for quality. So the first set is the idea of structure, process, and outcome. So this was developed by many years ago by somebody called Ovidis Donabedian. Remarkable name, but the concepts are very simple, that you can essentially describe the quality of something in terms of structural aspects. So in general practice, a structure could be the building, it could be a protocol, a guideline, the equipment, etc. It could be a process. So it could be what one does with those things. So the structure might be the telephone system. The process is how that's operated by the reception staff, the GPs, anybody else. And the outcome is what effect it has. And there are different types of outcomes. And that takes us to the next set of things. So there was a major reporter in the 90s called the Institute of Medicine, Crossing the Quality Chasm. And they developed this acronym called STEEP, you might have heard of. So safe, timely, access, effective, efficient, equitable, patient-centered. So it has an extra E in the middle sometimes. But that's been simplified by Aradazi in the next stage review into these three things. So 3 is easier to remember than 6, isn't it? Safety, effectiveness, and patient experience. And those 3 are really helpful to remember as important aspects of quality. Is what you're doing safe? Is it effective? And is the experience for the patient good? And all of those things are actually linked together. So they're correlated, but they're different. They're separate entities, and they're all very, very important. So, of course, you can provide very effective care. We all know this. You can be a great doctor. You can get the diagnosis right, do the right treatment, make the patient better. But if you give them a really terrible experience, they're not going to thank you for it. And they might even complain, even if you've done the right thing. So experience is very important. And then, of course, safety is another arm of that. And so you can cross-reference these things, the elements of safety, experience, clinical or cost effectiveness, and look at structures, processes, and outcomes. And you can draw a matrix, if you like, or a set of quality domains which categorize things according to structure, process, outcome, and whether they're about safety, experience, and clinical or cost effectiveness. Sometimes there's overlap with things. So with vaccination, the safety elements might be a vaccine checklist. The process is making sure you ensure aseptic technique, and the outcome might be infection or lack of it. So safety, you'll all know, is incredibly important. Hippocrates and first do no harm. There've been lots of public inquiries about safety going back to the Bristol Royal Infirmary scandal. Maybe that's before some of your time, but that was a really landmark public inquiry. Liverpool, around pathology samples, and obviously Shipman, mid-staffs. So public inquiry is all about patient safety. And we know that harms are common. 1 in 10 hospital admissions lead to adverse events. 2 in 5 are preventable. 50% lead to disability. That's huge, isn't it? And 1 in 13 of these adverse events lead to death. In primary care, many of you will have seen the work of Tony Avery and others looking at prescription errors or potentially preventable errors, and 1 in 20 prescriptions has a potential error. linked to it, 1 in 100 potentially serious. So that's safety. Experience, I think we all know how important experience is. We spend a lot of time learning how to consult well. Obviously, relationships have changed, haven't they, between the public and the medical profession over the past 30 years since I've started training. Some people talk quite a bit about satisfaction. And what's the difference between satisfaction and experience? Well, satisfaction is how happy one is with what one receives or gets. And the problem with satisfaction is if you're used to getting something really dreadful, anything is better than that. And sometimes people are so used to bad things that they can be satisfied with really not terribly good care. So I think satisfaction has been replaced by this idea of experience. So experience is a more detailed description of what people really want to receive and do receive. The difference might be, were you satisfied with your consultation, yes or no? Or on a Likert scale, how satisfied were you? Whereas an experience might be, was it explained to you what the problem was? Were you given an opportunity to discuss your problem with the GP? Did they give you a choice of what treatment you might want? So you could see that there's a difference between experience and satisfaction, and it's really about expectation. Satisfaction is very much dependent on expectation. The other thing is, people sometimes think experience is about what you're experiencing at the time. And although that's very important, what's just as important is your memory of what's happened to you, because that's what you're left with at the end of it. And what your memory of the experiences is very important. It seems an odd distinction, but it's worth remembering that how something ends and the peak experience is actually determining what the memory of it is. So if you can imagine a piece of music that you're listening to, your experience of it isn't, obviously you'll experience it at the time, but your memory of that experience is how the thing ends for you, but also the peak of the experience during the music. And it's a bit like a description of somebody who was treated for pain. And this is an MIT professor. When he was a child, had burns, and when he went into the burns unit, the nurses used to rip the dressings off him, and he hated it. And he said, "Well, why are you doing that? It's horrible." And they said, "Well, we want to make it quick for you, so we're going to rip the dressings off very fast. We think that's the best way to do it." And he said, "No, please don't do that. Do it gently, and it'll be better for me." And you can see that what he's then describing, and even as a child, he realized that if you take the dressing off slowly, the peak pain is lower and it ends well. Whereas if you do it fast, your peak experience is dreadful and it's ended very, very badly as the dressing is ripped off. So experiences of what health services and staff are like and do, and experiences of how they feel services enable them to be and do what they value during and beyond their health encounters are very, very important. And so that introduces the idea not just of the care that you're providing, but self-care as well. Clinical governance, you'll all know and have heard about, but I just want to summarize it in this way. It's about quality, but it's also about accountability. And it's only those two things. And it's described in very, very complex ways, but it's essentially about those two elements. And the accountability side came directly out of Bristol, where the chief executive at Bristol at the time said, well, it's not my responsibility, it's the surgeons who are operating on children with cardiac defects, and it's their responsibility. And the chief executive went up in front of the GMC and he was struck off because they said, actually, you're accountable as chief executive for what happens in the hospital. Because he happened to be a doctor as well, he was struck off. So the idea of accountability is very, very important. And then the ethics of improvement. People often think, well, if you're improving something, of course it's got to be ethical by its very nature. Well, that isn't true either, because if you do improvement badly, you could do harm. You could do it unfairly, inequitably, and you could contravene people's autonomy and right to choose. So although you might be doing good in one respect, you might not be in other aspects of ethics. So have a think about, is your plan quality improvement ethical? And we can have a look at how you decide that. So I think, put very simply, quality improvement is the act of analysing and solving problems. It's about troubleshooting, and it's the act of analysing and improving healthcare processes. And thinking about processes, everything that we do. So what I'm doing this evening, what you're doing, listening, everything that you do in your job is a process. And if you can't describe it as a process, you probably don't know what you're doing. Maybe you're doing it instinctively. I think that's okay. But actually, it's better to really understand in detail what you're doing and why you're doing it, and how you're doing it. And so quality improvement is about analysing, displaying, and improving processes. And there are a few ways that you can think about this. And Mohammed, when we talked about this seminar, said, well, what should you focus on? And what I would say is, if you're going to think about one thing, the starting point of all improvement is looking at it from the patient perspective. And so you need, either directly or indirectly, to find out from patients what they need. That sounds a bit odd, doesn't it? Because we're trained in providing medicine, and we talk about evidence-based medicine. But as I said right at the beginning, quality is not just about effectiveness and safety; it's also about experience. And so it's one of the things we often forget. And so I think it's one of the things we should think about. Are your patients getting a good experience? And the simplest way to find out is just to ask them. I spoke to a GP a few years back, and he said, well, I've done a satisfaction survey, and our patients are really satisfied. And I said, well, that's great. And I said, who did you ask? Well, we gave the questionnaire out to people in the waiting room. I said, okay, what about the people who didn't get to the waiting room? Oh, we forgot those, or didn't think about them. So, who you ask, how you ask, is actually really very, very important. So you can do, we often do interviews, but that's very time intensive. But actually lots of people have done interviews, so you can read interview studies to find out what patients want. So there's a lot of evidence out there. You can do surveys, and you can do experience surveys, but you can also directly observe what's happening. You can see what's going on in your practice. If you've got your eyes and ears open, you can listen to complaints, you can do significant event audit. So there are a number of techniques at our disposal. Obviously, you can measure things in terms of effectiveness, things that relate to guidance and so on. In terms of displaying processes, I'm going to just describe a couple of ways of doing that. One is a thing called a fishbone diagram or cause and effect diagram, and the other is a process map. And then improving processes, how can we improve? I'm going to show you some ways of thinking about it. Now, these are all ways of conceptualizing what to improve, how to improve it. And this is all about the planning and what you focus on. And it might seem to you, goodness, he's spending a lot of time talking about these things. Why doesn't he get to the bit where you measure something? Well, the reason I'm spending a lot of time talking about this is actually this part is much more important than the second part. You know, they're both important, but if you get this wrong, you then end up measuring the wrong thing, and you get a measurement and you can improve something or other, but it's not something that's important or relevant, or you end up doing more harm than good if you haven't thought about it carefully. So I'm probably teaching many of you to suck eggs, but I think these are things that need to be said. So a fishbone diagram is just a way of demonstrating all the things that are going on in a set of processes, and you summarize, you know, so patients, providers, policies, processes, equipment, outcome. You might think it's a bit odd to have patients in a process diagram, in this fishbone diagram. You know, what are patients doing? Well, actually, they're doing quite a lot. A GP a few years back said they'd introduced a telephone system to their practice. I've forgotten what it was called. It was called advanced something or other, the advanced telephone system. Anyway, their idea was that every patient who called into the surgery would telephone, and they'd go through to the reception, but they'd be directed to the doctor. So they'd have a telephone appointment that was a consultation with the doctor, so that they could be triaged into whether they needed telephone advice, whether they needed a consultation, etc. Which is great. Then she told me what had happened. She said the first day it was brilliant, and then the first week it was okay. After a month, it started to get really very difficult because the numbers started to pile up. And then after 6 months, they were all on their knees. They were absolutely exhausted, all the doctors. They were getting loads of telephone calls. And I sort of had a chat to her about it and said, well, you know, why do you think that was? And of course, what had been happening is before, patients had been doing a lot of work. They'd been thinking about, well, should I come? Should I go to the doctor? Who should I get advice from? Then they'd phone the receptionist. The receptionist would do some work, trying to figure out what they needed to do. And then they'd go and speak to a GP, a nurse, or whoever, or have some other sort of intervention. Of course, all of that work that the patient was doing and the staff were doing were cut out, and all of that work was falling on the GP. I'm sort of simplifying things slightly, but you can see actually the patients are a really important part of the process, and they can do a hell of a lot of work, or not, as the case may be. Process maps are more complicated. Sometimes people, you can draw them just with a pencil and a piece of paper, just describing every process that happens in sequence or in an algorithm. And this is a process map of somebody with chest pain being attended by a ambulance and an ambulance clinician, and all of the things that they have to do before. You can see right at the beginning, they arrive on scene. And at the end, it's transfer patient to vehicle. So it's only the bit between them arriving on the scene and transferring the patient to the vehicle. And this is a simplified version of all of the processes that are going on. So this is a process map, and it's a pretty useful thing to do, particularly if you can do it with patients or the rest of the team to try and figure out what's going on in your process. And one of the things then you can do in terms of improving is discuss amongst the team and or patients, what in that process is critical to the quality, i.e. effectiveness, safety, and the experience of the patient. This is a critical to quality tree about communication and communication about the heart attack. And again, this is somebody presenting with a heart attack and what you might need to cover in terms of the discussion. And you can devise these yourself, so you simplify what is critical to quality, in this case experience for the patient and possibly the outcome, in terms of this critical to quality tree. And then the other technique we use is a thing called a driver diagram. So you say, well, what are you trying to achieve? So it might be to improve delivery of care bundles. This is for heart attack to over 70% of patients within 2 years. So you're being very specific about what you're trying to do. And then you look at the evidence of what might help you to achieve that. So you might say, well, the primary key drivers to increase awareness of bundles and the components of bundles to the staff. There might be some behavior changes that you need to do, and you might need to redesign the processes. And then you look at the details of what you need to change to achieve that goal and those primary drivers. And then there are some theories, these change ideas at the end about how you do that. And the change ideas can come from the literature, the evidence, your experience of what works, but essentially they're theories of what might, could, and should work in a particular circumstance and in the context that you're working, because everybody works in a slightly different context. Your teams are different. I think there are some things that will be very similar for every context, but there may be other things that you'll need to tweak depending on your context. So this idea of theory is very, very important, and looking at the evidence of what works and what doesn't work. And that is what I'd encourage you to do as a starting point for improvement. And then we summarize the process, if you like, of improvement as this thing called a logic model. I don't know if you've come across this, but we use logic models for every research study we do, but also for every improvement project. So logic model is a very simple linear model of what you're trying to improve and how you're going to do it. And so you summarize the problem, the population, what your aims are, and develop an aim statement. What are the inputs that you're going to do to achieve the improvement? What are the outputs that you're looking for, and what are the outcomes? And then have a think about what are the anticipated outcomes, what might the unintended consequences be, and think about those in the short, medium, and long term. And this seems very long-winded to do this, but actually just laying this out on a piece of paper and thinking about it might save you a lot of time, hassle, and possibly harms of what you're trying to do, because there are always unintended consequences of any improvement. So we put in improvements with the best intentions, but it's important to think about the possible adverse effects. And then many of you will have come across the model for improvement, and it's three very simple things. What are we trying to achieve? How will we know that change is an improvement? and what change can we make that will result in an improvement? So the first thing is the aim, what are we trying to accomplish? Just to go back to that, I think you need to be very specific in what you're trying to accomplish. What are you trying to achieve? So it's an improvement in X over this period to a level of Y. It's that sort of specificity that you need. And so how will we know that change is an improvement? That might seem obvious from a clinical audit point of view, but I'm gonna show you some charts that might disabuse you of that. Then what change can we make that will result in an improvement? And that goes back to these driver diagrams and logic models to think very carefully about, what are you doing? What should you and could you do? What would your energies best be put into in terms of making an improvement? So you all know about audit. So it's about measuring performance against criteria and standards, repeating things until the standard is achieved and until you set a new standard. So it's essentially a before and after repeated. So you set criteria and standards, measure against standards, implement change, and it has to be based on evidence and some theory, and you remeasure. I think many of you will know that the systematic reviews around audit do show some slight improvement, but the problem with that is that many audits are not completed, they're not repeated, they're done badly. I think if it's done well, it can be a good tool. Quality improvement is slightly different, and people are often confused about the difference between clinical audit, which is a technique for improvement, but quality improvement uses a slightly different technique, and this is what I'd encourage you to use. It's a plan, do, study, act, cycle. And people often think, well, are they exactly the same thing? Well, they're not, and I'll explain why. So the plan is this logic model that I put to you earlier on. So what's the problem? What are the priorities? What's the population? What are the aims? What are the activities that you're going to do? And what are the outputs and outcomes, intended, unintended, and adverse? So that's your plan. The doing is around implementing it. The study is around measuring the outcome, and the act is about making a change based on that. And the thing about PDSA as opposed to clinical audit is usually a before and after repeated. PDSA is a rapid experiments, so they're short-term, quick, and they use statistical process control, so they use measurement repeated over time, and I'll explain why we do that. So this is a summary of the difference between PDSA and clinical audit. So you can see that the triggers are the same, review of evidence for change is the same, they both have criteria. PDSA doesn't have a standard because you're continuously measuring before and during any change, whereas the clinical audit is a before and after, as I said. The thing about audit is it's a bit slower because you implement a change and then you re-audit. Sometimes that takes a little while. Whereas PDSA, you can put in multiple changes at the same time, or different practices. If you're working with other practices, you can say, well, we'll try this and you try that, and we'll measure and see what happens. And you can do multiple changes in sequence or in parallel, one after the other, and you can see how things improve over time. And the key is to get an improvement over baseline. I'll show you a little bit more about that. So this is just about aims and making sure that they're very specific, measurable, attainable, relevant, time-based. So you set a time within which you're going to improve something. And this is because PDSAs are based on rapid experiments, I thought it's helpful to compare it to an experiment. So experiments are based on a theory. So this is this logic model, you've got and driver diagram, you've got a theory of what's going to make things improve. You predict how it will improve, and then you do the experiment, and then you observe what happens. So that's a PDSA. But it links very much to the whole idea of experimentation, and PDSAs are rapid experiments. When so I've worked as well as being a GP and a trader and working as a clinical governance lead in a primary care trust when such a thing existed, and then in an ambulance trust. The thing that these organizations were obsessed with, I don't know whether it's still the case, I'll hear from you, but that we're obsessed with league tables. I think balanced scorecards are a little bit better. Traffic lights, oh my goodness. I don't know if people still use traffic lights, but I know they're still used by some organizations, but I really hate them. Targets, I think they're dreadful. I co-edited a book on the quality and outcomes framework, and we had some amazing people write for us, including Barbara Starfield, and she wrote a whole chapter on how much she hated the QOF and why we should get rid of it, and why she hated targets so much. And there are some positives, but in general, because of gaming and all the negative effects, and also the fact that it probably wasn't the targets that led to the improvement. We need to think very carefully about the positives and negatives of sticking targets in. So here are league tables. They're shockingly bad because 50% are going to be above and 50% are going to be low, and you really don't know very much about from this, apart from, well, maybe the person that's at the top or at the bottom are doing something different, but I can't really tell anything from this league table. The other chart I saw, and I took a slide of this chart because somebody showed this at an executive meeting. This is in a major trust in these Midlands, and this is what they did with an Excel spreadsheet, and did a set of bar charts. This was oxygen administration to people with heart attack, and what they were trying to show was that things had improved, and everybody patted themselves on the back until I said to them, actually, it doesn't show anything of the sort. There isn't really any evidence of improvement there at all, if you plot it correctly. And the way to plot these things is using either a run chart or a control chart. I don't know if you've seen these before, but they're ever so simple. Essentially, you put the dates on the bottom, and this could be daily, hourly, weekly, whatever you want. It depends on the numbers, and then whatever measurement is on the y-axis, and then you plot it over time, and you can see how with using SPC and PDSAs that you can rapidly get an idea of whether things are improving or not. So this is what we call common cause variation. It's not changing at all, and I'll explain why. So common cause variation is predictable, it's due to chance. Many factors are affecting whether things are going up or down, and you don't really know what's happening. It's just part of the process, and it affects the process most of the time. So it's a bit like blood pressure, you know, you measure it from hour to hour, it will vary, it'll show common cause variation. Special cause variation is what we're interested in. It's unpredictable. It's due to assignable causes, usually few factors, can usually be identified, and it's not part of the process. It's intermittently apparent. And I think the nice thing about SPC and this way of measuring is that it'll tell you whether something's really improved or not. So in the PDSA, so there's plan, do, study. This is the study bit, and this is why if you use SPC, you can put rapid experimentation in and rapid changes. So if you look at January 08 here, and you look at the line, the dot just before, and you look at the dot, that's the highest dot in January 08. If you did an audit and you measured that dot before and then January 08, you'd say, oh my God, we've really improved things. This is fantastic, and everybody would be slapping their, themselves and celebrating, opening the champagne. But there isn't any improvement there. All you've done is to observe random variation in what you've been measuring, and if you continue measuring, you'll see that it was just random. So you congratulated yourself in error. And this is a run chart, and run charts are very simple to do. It's just a series of dots, as I said, and you draw a line, and the line is the median. So you draw a line through the middle value. So you arrange them all in order, and I think here, I can't remember, say there are 25 dots, you arrange them in order of size. The top and the bottom, and the middle one is where you draw the median through. So you'll know how to calculate medians. And there are simple rules for run charts. So, if you looked at this chart, so some people will say, oh, well, yeah, it looks like it's improved at the end, or, it looks like, or sorry, it looks like it's got lower at the end, or it looks like, it's got higher in the middle. Well, none of that's happening. It's just common cause, random variation that's going on. And here are some rules which everybody can use, which will tell you what's happening in that chart. So a run is a sequence of points, either all above or all below the median. A shift is 7 or more successive data points above or below the median. There's some tiny complexities in the rules, but essentially remember run, shift, or trend. And trend is 7, 6 data points going successively up or going successively down. So those are the rules for run charts. And the thing about runs is in a chart, you can derive a probability of too few or too many runs. And so you get a probability chart like this. So if you have 25 data points, too few runs is 9 and too many runs is 17. This is the only slightly complicated thing about run charts, but they're a lot easier to read because if you focus on shifts and trends, I think you could all see that if you look at the end of this chart, there are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 points, all below the median. That's a shift, 7 or more successive data points above or below the median. Okay, so if improvement meant getting lower, you'd have improved something. And this simple run chart tells you that you've definitely changed something there in that process. Is that okay? There are no trends there. There are no sets of 7 either going up or going down. But there are, it also breaks the rules for runs. I won't go into detail in that, but essentially you can see that there's a change. Control charts are just slightly different. It's a bit like the difference between an X-ray and an MRI or a CT. It's just a finer resolution of the measures. And the thing that you can see about this control chart is you can see some dotted lines at the top and the bottom, and those are called control limits. The nice thing about control limits is if something is outside the control limit, it's not right. It's a special cause. So the rules for control charts, again, are pretty simple. I mean, there are more complex variations of this, but a single point outside the control limit is a special cause. 7 or 8 data points above or below the mean. So control charts have a mean instead of a median, and these upper and lower control limits. And then a trend is 6 or more data points going successively up or successively down. That's it. I'm just going to give you an example of a study we did in Lincolnshire General Practice, but I can give you lots of examples that we've done locally, regionally, nationally. But in this study, it was called the REST project. I don't know if any of you were involved in it, but it's Resources for Effective Sleep Treatment. So we were trying to find out how you could treat people for sleep problems better in general practice. And the standard way of treating people, I don't know if it's still the same, but is a leaflet, sleep hygiene advice, or sleeping tablets. Is that right, Mohammed? Is it still the same?
I think there's a less of a focus on sleeping tablets now.
Yeah.
But the sleep hygiene is the first port of call. Yeah, absolutely.
Yeah, exactly.
Yeah.
So we all know how effective sleep hygiene is. Yeah, it's completely ineffective. but it's a useful thing to do. But it's not. It's got no real effect. But we all do it, and then then the patient's not sleeping, and then we resort to sleeping tablets when they're desperate and they can't sleep. We give them a little dose, and then a little bit longer. And then when we surveyed patients who'd been on sleeping tablets for 6 months or more, or no, they'd had at least one prescription in the previous 6 months. Now, 90% of them were on long-term prescriptions. 90% had been prescribed by their GP. A lot of the time, they hadn't been told to stop. And so these people were stuck on sleeping tablets forever. I asked one of the GPs, well, what's happening to the sleeping tablet prescribing in your practice? And he said, well, it's got to be going down because it was the senior partner who was prescribing them, and he's left, and all the patients on them, they must have died by now, so they're all dying off. Our sleeping tablet prescribing is definitely going down. But when we looked at the charts, it was going up. The benzos were going down a bit, but their Z-drug prescribing was going up, and it was all of these people stuck on these prescriptions. So we did quite a lot of work, really asking patients, well, what do you want? And this might sound blindingly obvious. My teenage daughter, my daughter, when she was in her teens, she said, you seem to be spending all your time finding out the blindingly obvious, because the patients who were on sleeping tablets, they said, well, actually, we'd like to sleep. They weren't sleeping on sleeping tablets. And so we thought, well, what do they need? Well, what they needed was a psychological treatment for sleep called cognitive behavioral therapy for insomnia, which is very, very easy to figure out and deliver. So we did survey patients and GPs, we did some focus groups, we worked with a group of 8 practices, and we looked at the effect on prescribing. So we measured prescribing, and we call this a REST intervention, but essentially we taught GPs how to do cognitive behavioral therapy for insomnia in 10 minutes in a primary care consultation. And it's dead simple. Patients can teach it to them themselves. So GPs must be able to do it too. And actually they can, and they were brilliant at it. And here's a this is a run chart. Actually, you can see it's a median with a load of dots. No change. It's common cause variation. Again, you can see, if there are a couple of dots somewhere there, and you did an audit and it looked before and after, you look at that dot in January 2008, you'll say, goodness, we've done a brilliant job. We've reduced sleeping tablet prescribing, but actually you're just measuring common cause variation. This is a little bit better. So this was a practice, and look at all those dots at the end to the right of that chart, and you can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 dots, all below the median. So they've had a significant change in prescribing, and all we did was to teach the doctors and nurses how to do cognitive behavioral therapy for insomnia. And here's another practice that was involved, and you can see they were quite high at the beginning. They did something before we started to do some work with them, and you can see that there's a significant drop in the middle there, and then there's another drop at the end when we started to do some work with them. If you don't believe that, you can look at this chart. This practice did cognitive behavioral therapy for insomnia for their patients, but they also withdrew every patient from benzodiazepines in their whole practice. You might think, cracky, how did they manage that? Well, they did a gradual withdrawal program. They did a switch from short-acting to diazepam, and they used psychological therapies for insomnia. They were in a rural practice in the middle of nowhere, so their patients couldn't go anywhere else. And we did ask the patients, how were you? And most of them were really happy. But the key thing was they said, well, we trust our GPs to do the right thing for us, and they told us to come off the tablets, and they helped us. And we're pretty much sleeping much the same as before. So some were sleeping, some weren't. So what I hope I'm showing you is some ways to think about quality improvement. I think this is just a summary of how you could think about designing a quality improvement project. So a title, rationale for your choice of topic, and I describe the ways that you can choose something that's important to your patients and your practice, do some process mapping, think about the priorities, think about some techniques used to improve the processes, essentially developing some theory through a driver diagram, looking at the evidence, to do some baseline data collection, and really do some run charts, which for the technology you need for doing a run chart is a piece of paper, a pencil, and a ruler. That's all you need. Of course, you can do it with an Excel spreadsheet, and there's software that you can do it with, but you don't need anything more than a pencil and a paper. And then, obviously, in terms of maintaining change, you can see whether things are really maintained, and you can see on that this chart here, we checked what was happening. We looked at their prescribing data 2 years later, and it was still very, very low. I think there was 1 or 2 patients who went back onto short-acting hypnotics, but it wasn't very, very many at all. So think about knowledge, skills, performance, safety and quality, partnership, teamwork, communication. I think this is a team endeavor, any improvement. And when we've done it at a regional level and that national level, it's always been done in small teams on a small scale with rapid experimentation and then spread much more widely. And we did one national project where we improved the care bundles for heart attack and stroke, or the heart attack care bundle, which is painkiller, oxygen, GTN, morphine, and one or two other things. At the start of it, it was around 40% got everything in the bundle. At the end of it, it was within 18 months, it was 70. It was nearer 80% achieved the care bundle, and for stroke, it went up from 80 to 96%. So again, if you set targets, if you set a 70% target, you wouldn't do anything with the stroke care bundle because they were already above 70 to start with. But actually, by using this type of methodology, using statistical process control, you can see significant changes over, even when you're at high levels of performance. So you can learn a little bit more about this, and this is a free resource that we developed from the book called QI Learning. So there's the website, and I think, Mohammed, you're very welcome to share these slides afterwards so people can access these resources. And then obviously, I don't know whether the book is still in circulation, but certainly we're writing a new text. I'm writing a new text with a colleague, and hopefully that'll be out next year. So there are my contact details, and I'm happy for you to contact me and provide any further information. And I'm very, very happy to answer any questions as well. So I'm going to stop sharing my screen. I can work.
I think we can still see your screen at the moment.
Yeah, I'm sorry. Just trying to yeah, I do apologize. For some reason, here we go.
There we go. Thank you so much for that. It's very interesting and something, a lot of it very new to me, particularly, and definitely more for me to look into for improving sort of primary care processes. Well, it's great to hear from you. If anyone has any questions, then feel free to ask. I certainly have questions, and I'll start with mine. So it was interesting how much you focused on the patient experience as being a sort of a key indicator for improving quality. I'm just wondering, my observation of general practice as a whole has been that sort of the healthcare has improved, or the care that's provided has improved, or people's health in general has improved, but I really don't think patients' experience has improved. I think that's going downhill, but that's just my observation, and I'm not sure if you agree with that, if you have looked into that yourself more, or but it's just a interesting observation that you put so much focus into it. Yeah, I think that's something that's getting worse.
Yeah, so I haven't looked at it specifically, but there are people who look at patient experience using the primary care experience survey, and there are suggestions, as far as I'm aware, that some aspects of primary care experience are getting worse. But you can see, using the techniques that we've talked about, that actually it's not too difficult, and I think it's within everybody's capability, within the practice capability, to think about that and then figure out how to improve it. You're the experts. Many of you will have been doing this job for months or years, and you'll have a really good sense of what things patients want. But you could ask them. Some of the things are obvious. They don't want doctors. They want doctors who listen, who take them seriously, who are empathetic, who consult well, who are not focused on the keyboard, looking at the computer screens. All of that's obvious, and you can measure people's experience just by asking them simple things like that.
Yeah. I suppose another question I had was sort of at the moment I'm doing video consultations a lot, or telephone consultations a lot, and I find depending on where I go, sort of a different percentage of appointments are probably appropriate for telephone, appropriate for video. Some people are filtering them very well, others not so well. So if I wanted to do a quality improvement project on improving the number of sort of appointments that are booked that are appropriate for remote consultations, so how would I go about that? Because you talked about a few different models, and what would you think would be the best way to go about that?
Yeah, so that's a really brilliant idea for improvement. So so have a think then, Mohammed, about what the measure would be. Have a think about, well, what is it like from the patient's perspective as well? You know, what would they wish for? I think in terms of thinking about it, one of the things I would definitely do is to map out the process. So what is the process that's going on in your practice when a patient phones up? You know, who's talking to them? What are they saying? How are they deciding? Some of this requires you to go inside the head of whoever it is making those decisions. It may be a receptionist, it may be a nurse, it may be a combination, and think about your processes. This is one of those situations where you need a team approach to decide how to improve something, and actually sometimes involving patients in the process mapping can be incredibly useful, because they'll tell you what's helpful or not. And some things that you think, oh yes, patients will think that's really important, they'll say that actually no, we don't. We don't think you need to worry about that, or you need to worry about this side a little bit more. And so you might think, well, you know, this all sounds very difficult, but actually it is. You just need a few people who are your critical friends, who want to improve things with you, who will help you. So with every research project, you know, we have a group of patients who are involved in every project in the design. And that first project with sleep, for example, I said to our patient group, well, I think we're going to focus on people with mental health problems and sleep problems. And the chap, this is before I put a bid into the Health Foundation, he said, why are you doing that? There are loads of people out there with sleep problems. They haven't all got mental health problems. And to be honest, I didn't understand that before I started to learn about this. And he's absolutely right. Most people with sleep problems haven't got mental health problems, but they've got sleep problems. Process mapping involve the team members who are part of that process, or even who might be affected or, you know, indirectly part of it. Try and involve patients, map out the process, see then what is critical to the quality experience of that person, and as well as getting the right people charged to you. And then, as I say, develop a logic model of what will be done, who'll do it, and implement some small changes based on theory and start to do some measurement.
It sounds like a good starting point would be getting a team together and doing a process map, just to get an idea of exactly what happens in the surgery. And then think about which part of the process map, I suppose, you could do something about, or look into what sort of evidence is there that exists sort of in the literature as to what helps, I suppose. So that would be a starting point.
Yeah, brilliant. And how often do we do that?
To be honest, it's only after your talk that I'm thinking like that. I don't think I've thought about quality improvement projects previously in that way. My normal way of thinking about it would be, what can I do? What do I think happens?
Yeah.
But yeah, no, I get what you're saying. Get a process map and get everyone to contribute to it. That way, you've got a clear idea of what actually happens in the practice. That does make a lot of sense. Yeah.
Yeah. So absolutely. The reason why that approach is so important is all of these things involve human beings, and so it isn't a sort of sterile, artificial environment we're functioning in. To get change happening effectively, you do need all of those people involved and bought in and owning the problem with you. So that's the other part of this whole process. It's about leadership and getting other people in your practice involved, and they'll really enjoy it, they'll contribute to it, and they'll make it happen. And these are some of these contextual factors that are very important.
Great. No, I think that's definitely quite a different spin on it for me in terms of how to think about quality improvement. Yeah, I was interested to know actually, how long does it take to teach GPs how to do CBT for insomnia?
Well, I reckon I could do it in half an hour.
Oh, really?
Probably,
okay.
Maybe an hour. But it doesn't take very long. And if you actually wanted to learn how to do it, we've set up a website called the REST Project website.
Okay.
And not only does it teach you how to do it, if you like seeing somebody doing it in 10 minutes, the GPs who are involved in the project were filmed doing CBTI. It's called CBTI, CBT for insomnia. And so it's dead simple to do and learn. Patients can teach it to themselves. One component of it, sleep restriction, so it's got 5 components, essentially. Cognitive, sleep hygiene is a component, because whatever you do, if people are drinking a quadruple espresso before they go to bed, they're just not going to sleep, are they? So you need to tell them simple things like what to do and what not to do. There's an element called stimulus control, and there's a technique called muscle relaxation. So there are 5 things that you need to learn, and they're dead simple. But if you go to the REST Project website, you can teach yourself how to do it.
Sounds great, because since I've been doing remote consultations, I've been getting a lot more of those problems directed my way. So yeah, sounds great. I'll give the opportunity to anyone to ask any questions if they wish to. You can either message on the chat or just turn your microphone off, turn your microphone on, and just ask your question directly if you wish. May not be many questions. It's very close to bedtime.
Yes, everybody's shy or very tired. But
Yeah.
I can fully understand. I'm really grateful to everybody for giving up their time and coming and listening.
People are just saying thank you in the chat. Yeah. Okay. If we don't have any more questions, then we will.
Victoria wants to assimilate a bit. Oh, yes. So yeah, and I did put the website on the QI Learning website that you can get a little bit more information. There are various webinars, and there's more information about SPC and the other techniques involved.
Great, thank you. And yeah, I think people are just saying thank you. Not a question, but a great talk. Mohammed answered the question I had asked the question regarding 10 minutes. I will definitely look at the REST project. Great. Sleep web, I think people like the sleep website. Yeah, lots of CPD. I think I'm definitely going to have a look at that because that sounds really useful. Okay, any other questions or comments, feel free to post. Otherwise, thank you everyone for joining, and special thanks to Professor Nero for joining us and going through quality improvement, a brief overview of it, and that's absolutely fantastic. And hopefully, I'm sure we'll come across at some point in the future, and I hope everyone benefits from it, and we'll put the recording up so that other people who weren't able to make it here today can also benefit from it as well. Thank you very much.
Lovely. Thanks, Mohammed. Thanks, everybody. Great to see you.
Yes, I shall send the slides as soon as I get them. I will do. Take care then.
Okay. Bye now.
Bye-bye.